And with that, we move ahead with Dr. JASLEEN DHILLON with us, and she's going to give talk on pragmatic evaluation of the efficacy of pilocar I.
So good morning, everyone, and thank you so much for giving me this opportunity. I'd like to say that I have no financial interest in this study. So we studied the role of pilocar I eye drops in the current scenario by evaluating the impact of the commercial non-availability of these eye drops over a period of 9 months. So we studied the efficacy and role of pilocar I in 2% and its fixed dose combination with timolol 0.5% in IOP control and reducing the need for surgical intervention in select poor prognosis glaucoma eyes on maximal tolerable medication. So we know that pilocar I has been one of the oldest glaucoma medications, over 100 years old, but is not very commonly used because of its frequent dosing that decreases compliance, side effects, and the advent of PG analogs. So this was a retrospective study. There were 88 patients, a heterogeneous group of open angle, angle closure, and secondary glaucomas with a minimum of 6 months on the medication. There were 2 groups. The first one had pilocar I 2% in TID dosage, and the second group had the fixed combination of pilocar I 2% with timolol in a BD dosage. From the electronic record, we identified patients over a period of time from July to December who had been on these medications, and because of the commercial lack of these eye drops, were not able to continue pilocar I further. So the age, gender, BCVA, CD ratio was noted, the glaucoma was staged, and the IOP was taken on pilocar I an average of 2 readings, and the IOP of pilocar I also an average of 2 readings, at least a month after the pilocar I had been stopped. Those who were on a fixed combination were shifted to timolol before the pressure readings were taken. The time period of the medication and the need for surgical intervention was noted. So the main outcome that was studied was the mean change in IOP of pilocar I, and the other outcome was the requirement of surgical intervention. And if so, the relationship with the time period of pilocar I, the mean IOP change, and the grade of glaucoma. The statistical analysis was done as indicated. And so there were 56 male and 32 female patients with a mean age of 63, and 38.64% were on pilocar I and 61.36% was on the fixed combination. The diagnosis, we had about, most of them were secondary glaucomas, about 45%, and of these, most of them were post-VR surgeries. The glaucoma was advanced in nearly half of them, and the number of anti-glaucoma medication was fairly evenly distributed, with the pilocar I being the 4th or the 5th medication in many of them. It's interesting to see that a lot of patients were actually allergic to one or more anti-glaucoma medications. And the prime outcome was that the mean IOP of pilocar I rose from 16.23 plus minus 4.53 to 25.05 plus minus 8.03. And this was a mean of about 8. The percentage increase in IOP from baseline was similar in all the 3 diagnostic groups, whether they were open angle, angle closure, or secondary glaucoma patients. And the need for intervention was there in about a quarter of these patients, and most of them either went for a trabeculectomy or a trab with cataract, and for those where the symptomatic relief was required, it was DLCP. And this need for intervention did not vary with the stage of glaucoma or the time period of the pilocar I, but was statistically dependent on the increase in IOP. So the median IOP change in the group that needed intervention was 10 millimeters, ranging 8 to 16, versus 7 in the group that did not need intervention. Also, 6 of the eyes that underwent intervention actually were on pilocarpine only for an interim period. And 6 of the 9 TRAB eyes and 3 of the 7 eyes that underwent combined cataract plus TRAB had undesirable IOP range. So we all know that there is the concept of target IOP. However, there is a lot of debate on what is exactly optimal for each patient. So there are certain patients where the benefit and the pros and cons are such that we may have to opt for an additional glaucoma medication. And of course, pilocarpine was not very much favored as a first-line medication or even a third-line medication because of the fact that it has compliance issues, since it needs a very frequent installation, at least 3 to 4 times a day, and also the incidence of brow ache and refractive changes. So in our study, we have seen the effectivity to be about similar to what was studied by West et al., which is about 8.21 millimeters mercury. And the mean decrease in IOP was much more than what has been reported in the very few select studies that are there. And it was also seen that the twice daily administration was equally effective to the single user pilo as 3 times. And we found equivalent rise in IOP in all the 3 categories, which is not so.
Time is up.
Okay. So we did not have any patient that stopped the use of pilocarpine for any tolerability issue. And adding the 3rd or the 4th medication, it was similar to Neil Cunton, who saw that there was about 40 to 60% of patients show a drop in IOP. But does this really continue in long term? That has to be seen. So it was a retrospective study with an inconsistent really follow-up visit. Lack of control group is there and a lack of long-term follow-up. But it is it holds promise, and in adult patients who are on maximal tolerated medication, as it can decrease the need for surgical intervention. These are my references. Thank you.
Thank you. You said that the pilocarpine was given when you had a combined surgery done.
No.
Cataract surgery when the pressures were high, even after.
Those were the interventions, the patients who needed intervention. We basically used it for patients who we were not planning to go for surgery. There were 6 patients who were on interim use because either the other eye had been operated or because they had another surgery, and so this was to be delayed. So that was in about 6 patients.
So this was the single drug which was in the other eye, which you think that the intervention was required? This was a single drug, or along with?
In majority of them, it was the fourth or
drug.
the 5th drug.
Okay. So did you see a additive effect along with PG analogs in any of the patients who were with PG analogs? Usually
Yes.
it is said that both the drugs have an opposite kind of mechanism of action.
Yes, we have not particularly picked out that group separately, but we have seen that the additive effect of pilocarpine when the pilo was off was fairly significant, like 8 millimeters was the median. So anybody who had an increase in IOP of over 10 needed an intervention eventually. So it did bring about, even in absolute eyes, it did bring about that effect that the patient was comfortable, and we did not have any of them report any brow ache or any need for removing of the drops. It was also very useful in those who have multi-drug allergies, where possibly this was the 3rd drug.
Okay, thank you.